Thank you. Hello, everybody. So I hear your pain over there in a hospital environment. So I'm a predominantly hospital palliative care physician, and I come from acute medicine. I'm a hospital animal, so I hear it, and I would say that we have got ourselves in a lot of mess with some of these conversations that we're forced to have, and we are running the risk of harming our patients, and the bottom line is we should never harm our patients, and so we are in a bit of a mess, and it's tricky ground, and I'll try and help a bit if I can. I wanted to start by saying that difficult decisions at the end of life are difficult because they are difficult. Okay, so you have to validate the struggle that you're having. Okay, this is really, really complex work. We are dealing with very, very vulnerable patients and their imminently bereaved families. So this is very, very difficult work. I just wanted to say it at the beginning. I don't want it to be underestimated. And the reason I'm worried is the strapline here, that end-of-life care is everybody's business, almost downgrades it a bit for me, all right? Because patients who are dying don't look like this, all right? So patients who are imminently dying within hours to days of life look like this, and you can't really miss these. And actually, once they look like this, it's relatively easy. But it's the people who don't look like this, who are going to work and raising their children, who are developing chemotherapy resistance, who've got awful symptoms and are trying to live their life, who are massively disabled from their neurological disease or whatever it is, that are the ones that we really, really struggle with, I would say. It's when the dying is not barn door, but we can sort of see it coming, but the patient and the family aren't ready, and neither is the oncologist and neither is the neurologist, but you as the GP can see it coming. That's when it's really, really hard. So this is difficult stuff, not just because the conversations are difficult, but the decision making. Who is dying and who isn't dying is extremely difficult nowadays. We can do so much for our patients. And it was interesting, really, when this is the new vision for palliative care and end-of-life care that will be coming out and will be the basis, I think, of a rewrite of the 2008 end-of-life strategy. And I think you will see in there this bit here, that all staff are prepared to care. All right, so this is everybody's business, and that is a strapline, and I do agree with it. But the staff need to be able to prepare to care within a system that allows them to care. All right, so with adequate resources on the wards, enough nurses to do the care, to wash the patients, to make sure that they're comfortable, and a hospital environment or a primary care environment where end-of-life care is high priority and is core business and is taken really seriously. So we all are all prepared to care, but many of us are in positions where it's very difficult to care when you admit 1,500 patients a week into Wexham Park Hospital, and between 20 and 40 of those will die, and we've got to spot which ones of those are going to die. It's very tricky. So interestingly, the cases that you've selected are, I think, from the Ombudsman report, Dying Without Dignity. One of those cases I was personally involved with, so it was a bit of a shock when I read the reports, and there's always two sides to the story, but I won't go into that. And what this, I don't know if you've read this report, it's very heartbreaking reading. It's 12 cases of descriptions of difficult deaths where mistakes were made. And from that we had themes, learning themes that came from the Ombudsman report. They came from all settings, these deaths, but most of them were hospitals, I will say. The majority of them were hospitals. And what's really striking for me is that these patients weren't imminently dying, they were months off dying. And it was the fact that we didn't recognise the dying that caused all the distress that followed, so the poor decision making from the lack of identification of the dying. So these are the themes, and right at the top is that we haven't noticed that this patient is dying, or maybe we haven't noticed, but we have noticed that we can't go there today, or the patient can't go there today, or we haven't got time, or we haven't got the agreement with the ITU team, or we haven't got the agreement with the oncology team. And so we haven't got ourselves in the zone, and the patient in the zone, and the family in the zone. And I would argue with you that if you don't do this bit, if we don't spot them, then the rest will not follow, all right? So once we've noticed, and we've packaged it up, and we've made ourselves really safe, and we're not going to get it wrong, and we're not going to tell somebody who's dying that they're dying and they're not dying, and the oncologist is going to give them another course of chemotherapy, then the rest follows. But for me, this is the real challenge for all of us, spotting those people that are dying, particularly in frailty, particularly for you lot out there in general practice, trying to spot your patients for your end-of-life registers for your 1%. And of course, this is what we're trying to avoid. So this is what the Ombudsman report showed us. You know, everybody having their chemotherapy going on, having their endoscopy, whatever it is they're doing. Oh my goodness, and they die by mistake on the side, and the crash team is there, and the family complain. And they don't complain because they're shocked by the death. They complain because they didn't know it was coming and they weren't ready. And that's what we've got to do. Okay, so this is really, really difficult work. Really, really difficult work. The identification is difficult, the communication is then really skilled and really difficult, and the allocation of resources for this enormity, which is going to sink hospitals if we're not careful in this country, is really difficult. I would say it's specialty work. All right, so I get it, it's everybody's business, but you need support from people who are expert communicators and with the resources and the teams behind them, and it's massively under-resourced. There we are, that's my plug. And I would say to you, as a country, we're probably a little bit muddled up about which patients we're talking about, so we are swamped, aren't we, with bits of paper and policies coming from the Department of Health, and they keep talking to us about different sets of patients. Okay, so the End of Life Strategy in 2008 was all about the last year of life. It was a great piece of work, lots of buy-in from lots of people who care for people who are dying, GPs, palliative care physicians, oncologists. The Newberger report was about the last hours to days of life. The 5 priorities for care, again, last hours to days of life. One chance to get it right, last hours to days of life. This is the easy bit at the end, and we've got all this noise here about this. But actually the real issue is identifying patients who might die in the last year of life. And the CQC end-of-life hospital inspections, we've got them coming again in October. I'm in a state of absolute terror about that. It's extremely intensive work. It's all about systems for identification for patients in hospital beds, not just how we care for those who are dying, but how we spot people who might die, and how we work across the boundary into general practice and with specialist services to manage their journey and care after death. How we manage the body, how we manage the mortuary. Okay, so I will tell you that dying is a long-term condition. I looked this up. I looked up the definition of long-term condition. It fits. All right, so here we are. It's an abnormal health state that ends up with mortality. Okay, it's just to make the point. Okay, you don't die like that. We deteriorate and our bodies deteriorate and we get sicker and sicker. So there is an opportunity to advance care planning, but working out when you do it within that deterioration is really tricky. So this is how we're teaching now, medical students coming through and junior doctors, is that you in general practice work with the mantra of the last year of life. I think so you're trying to spot patients who you think are likely to die in the next year. And within that, this is the timeline, the disease trajectory here. This is the death here. And you can see that this patient's going to work and having their chemotherapy or whatever it is, and then here's their first episode of hypercalcemia or whatever it is. Here's the decision point, the crisis, and there's an opportunity for you in general practice to talk to your patient really about maybe where are we going. Here's the phone call from the oncologist saying, oh, I think I've got chemotherapy resistance here, I've got no more lines of treatment. Here's the spinal cord compression, here's the bowel obstruction. So these are the points of crisis known in the literature as decision points. So for you in general practice, we're asking you to look for these things because we are learning that oncologists are not particularly good at doing this work in clinic, and they don't have the luxury in some ways that you do of knowing the family and the dynamic and the social setup at home. The other reason I put this slide up is I just wanted to put this picture in at the end to show you it's a tiny bit of all of this. Okay, so it's a really important prognostic group which we manage on care plans, but it's only a very small part of the journey of the patient. So in reality, in hospital, this is what we are doing, okay? We have patients who are living, and we would do anything to save them. So if they come in from their RTA, we would stick them on ITU and stick tubes everywhere and open their brain up and do whatever we need to do. We've got patients who look like this, who are dying, where the focus of our care is on their comfort and their dignity, and that's all we care about. Survival has slid down the list of priorities. But most of the stuff that we're struggling with is this bit in the middle, okay? So this is people where we've put ceilings of care in. So that patient with COPD might not go to ITU, but they might have NIV on the ward. They shouldn't be for resus, but we might give them antibiotics and other things as well. So we're running an acute care plan alongside a de-escalation plan. And that's actually most of the time what you're doing in general practice. Would I admit this patient with dementia into hospital or not? Would I admit this patient with cancer? Would I treat their hypercalcemia or not? So this is the tricky area here. So this is the identification of patients who might die, not will die. Am I making sense?
Yes.
Yeah. And so Pippa talked about working in context, and we talk a lot about this to junior doctors. So it's about getting your head in the right place. So I quite often see, particularly on the frailty wards and the care of the elderly wards, everybody working absolutely out of context. So going all hell, day 46 of the admission, treating the fourth aspiration pneumonia with the artificial feeding running and goodness knows what else going on. This patient is far more likely to die than live. So why are we working around the other way? And I think we often get lost in the care of the patient in the detail. So the junior doctors are measuring the urea and measuring the blood gases and doing all right in the detail. And the consultants sometimes are unable to stand back and look at what is in the bed and use their experience and their wisdom about what is the likely outcome for that patient. And we know it's really, really important to identify patients that might die or are more likely to die than live, because we know that the core philosophy of the patient, which will be based on their prognosis, will influence their choices about treatment. So if you talk to them about the fact that they might die, they may choose different treatment options than if they don't know they might die. But I know that also, as a doctor, I will do different things to patients with a short prognosis to patients with a long prognosis. So somebody with a prognosis of 10 years is very likely to make it all the way to intensive care. Somebody with a prognosis of just 1 or 2 days is not going to intensive care. So we will make different treatment choices depending on the likely survival. So why is this so difficult? I'm going to start with doctors first. So we are human beings, we are sadly human beings, and the literature is very clear that we overestimate survival. Okay, so we are wildly overestimating our patients' survival. That's something to do with us, I think, in some ways not being able to quite bear it, but also not wanting to give such terrible news if we might be wrong. Okay, so we don't want to tell somebody they're going to die in 2 weeks and then they don't. That's a terrible thing to do to somebody. So we tend to give everybody the benefit of the doubt. So we do overestimate survival. And I will say to you, the further away the death is, the more inaccurate we are. So we're pretty good at estimating survival when the death is very imminent. So when the patient is in the bed and is within hours to days of dying, it's quite obvious that they're dying. But the further we get away from that, the more inaccurate we become. Just keep it in your head though, it's a really good hot tip. So if you can't get off the fence, if you can't work out whether or not that patient is dying, and they probably are, if you remember that that's what you're doing, it's really helpful in practice. And it's partly also because we're sort of stuck in these clinical outcomes, aren't we? We're trying to keep our patients alive, that's what we're trained to do. We're trying to keep them comfortable and manage their symptoms. We're trying to make them independent, we're going to re-able them or rehabilitate them and all those things that we do. Nobody mentions the fact that that might not be possible, and we're trying to get them out of hospital or keep them out of hospital. I know there's a team of you here, which is a hospital avoidance team. There's a great big bit going on here about keeping people out of hospital. So we're all banging away at these clinical outcomes, which sort of miss the point a bit, really. Physicians overestimate survival. We wildly overestimate survival if the patient is young. Okay, so we get worse at it the younger the patient, the more we can't bear it, we get worse. I'm just going to say this, female physicians are worse culprits here than male physicians. Okay, I don't know why that is. But also the other thing I wanted to say to you is that we overestimate survival when we're not very good at prognostication. So if we know that we can't do this work and we don't know how to do it and we're not very confident, then we will absolutely err on the side of caution and we won't get off the fence. We'll keep treating the patient, we'll keep giving them antibiotics or whatever it is we're doing. For those nurses in the room, I will say to you, you're no better than doctors or no worse than doctors, so I just wanted to say that. But if you put us together, we are better. So if we work in teams, if you work in GSF MDTs, and the nurses are going to say to the doctor, I think this patient might be dying, that is a really useful hint. When you put your heads together, this is really very useful. So we certainly teach the junior doctors now, if the nurses say the patient's dying until proven otherwise. Okay, you have to listen to each other because you will all have different views and different focuses in the care. Your patients will want to know most of the time, not all the time if they're dying, but they are wildly over-optimistic. So that is out there in the literature, so you've got to move yourself, you've got to move the oncologist and the team around you, and then you've got to move your patient as well. So this is hard work, tricky stuff. And actually really what you're doing once you've identified the dying is you're moving your clinical outcomes to something more meaningful for somebody who hasn't got much life left. Okay, so you're sliding the survival down to the bottom of the priorities. It doesn't always go. There are some patients who want to live at all costs. We've met them, haven't we? Whatever the suffering, whatever we have to go through, keep me alive, keep me alive, keep me alive. We've seen these patients. So you never dismiss the survival, but it's quite likely to slide down in the priorities, and other stuff comes in that doctors don't normally think about. I suspect nurses do think about, but care of the body after death, well, doctors don't get taught any of that stuff, but it starts to become, you know, what are the religious requirements for this family? Do we have to get this patient back to Pakistan within 24 hours? All those kinds of things that we need to deal with. And the spiritual support becomes really important. So religion and spirituality is very important at the end of life. Okay, so that was doctors. So you're all out there wildly, and nurses, wildly over-prognosticating, as are your patients. The other things we know about patients is that patients plan for death. They can plan for death, but they can't plan for dying. Okay, so they seem to be able to do the DNA CPR bit over there because it doesn't yet apply. Okay, so that we seem to do the DNA CPR first before we do anything else, because somehow being dead is okay, but suffering and being dependent and losing your dignity is not all right, and it's a really difficult place for people to go. And actually it's the dying bit that causes all the suffering, not the being dead bit, usually. So the DNA CPR is the place to start the conversation, but I will say to you, and this is particularly to you, it should not be a standalone conversation. It has to be part of a bigger end-of-life conversation. You can't do it on its own, and if hospitals are making us do that, they are doing us a gross disservice, and if that's what we have to do, then it needs to be done and resourced with specialist communicating teams. I think that's my view. Some patients do want to discuss their dying, but the time to do that is initiated not in the acute setting, so we can't expect the hospitals to do this for us. So when people are acutely unwell, they don't make good decisions about what they want for themselves. So the hospital really has a duty to rescue the patient, resuscitate them, get them back home, ring you up, or write the discharge letter. You need to get round there and have a conversation with the patient, because the right place to do this is in the community when things are stable, not when they're acutely unwell in hospital. So there will be situations in hospital where we're going to do this, we do it all the time, but it's our communication across the boundary really with primary care, the flagging of these patients, the identification of these patients, and supporting you in general practice to let you know that we see it as well, and it's right to go for it and you're safe to go for it is really important. Patients, if you ask patients in the literature what they want when they're dying, they'll all talk about pain, won't they? It's all about pain. We know pain is usually irrelevant in the dying. It's not that's the problem. Pain is easily managed most of the 95% of the time. So it's not about pain, but I think that's what people fear the most. The big bits that I see are about control and autonomy, which is why these conversations are so important. So they can't have control and autonomy if they had no idea that they might die, and they can't make the decisions that they need to make if we haven't told them that they might die. And there is a point at which their quality of life will take precedence over their survival. That's very individual, and the skill is knowing when your patient is there, okay, when your patient is able to put the survival to the bottom, and that takes a bit of work and a bit of relationship building. This is a massive theme in my practice. I don't know if it's for you out there in primary practice, in primary care, but we do not want to burden people that we love. We really don't want to do that. So we raise our children to be independent and have a great life, and we really don't want to ruin it for them as we get elderly and frail. We don't want to block hospital beds. We don't want to block beds for people who we feel are more needy or more worthy than we are. So it's very much out there in the population. People do not want to burden their loved ones. I just wanted to put some of these things in, so what the public think. As death becomes more acceptable the older we get, and that's very clear in the literature. Most people want to die, if you ask them, between the age of 81 to 90. So that seems to be, so we don't want to be extremely elderly. We know that that's undignified and burdensome and is associated with suffering. Most people want to live well and then die quickly before they're extreme elderly. So only 6% of people, if you ask them when they're a little bit older, over the age of 65, will want to live beyond 100 years. So we all know, by the time you hit 80, 85, it's coming your way. So, are there systems to identify patients? What are the opportunities? So this is my view. It's not set in stone. You know this, we've got a massive problem. We've got a huge wave of dying. It's a huge wave in the ageing population, multi-morbidity and frailty coming our way, where the identification of dying is going to be very tricky. And if we don't do things differently, then we're going to have to increase hospital beds by 20%. By 2030, just to deal with the volume of dying in hospitals. So dying is going to sink district general hospitals unless we look at the systems and the processes that we use. And the reality also is that dying isn't what it used to be. So we used to teach on these disease trajectories, which were lovely and predictable, but we now know that people have, over the age of 85, have 3 or more conditions. So they have multiple disease trajectories, and working out what they're dying of and which disease is predominant at the moment is really, really tricky. Is it their dementia? Is it their heart failure? Is it their renal failure? Is it their cancer? Is it their, what is it? What are they dying of? Which is the most prevalent disease? These are complicated patients. It takes hours of time to unpick 5 volumes of hospital notes to work out whether this patient is dying and what they are dying of. So really, probably where I've got is that we probably ought to integrate palliative care services outside of prognosis. It doesn't really work. So prognostic groups looking for the last 1%, in the last year of life is really tricky. We need to look at systems where we wrap palliative care around acute care so that we can move patients gently into that way of thinking really, rather than really abruptly. So I'm a hospital palliative care physician, and this is the reality in hospitals. So in a hospital like Wexham Park, so 500 beds, we run a caseload of 50 patients at any one time. It's an extremely busy service with 1 consultant in palliative medicine. We know that in the last year of life, the average people have 3.5 hospital admissions. So there are opportunities in hospital to find them and talk to our colleagues in general practice and let them know that we're worried that this patient might die and can they please get onto it. Once they get into a district general hospital, it means that they're sick. So nowadays, you've got to be pretty sick to get into hospital, and 1 in 3 will die within a year if you get into a district general hospital. And if we cohort those into the really high-risk patients, so patients who are male, come in through A&E, through an unscheduled admission, extreme elderly, over the age of 85, on a medical ward, then 1 in 2 of those will die within a year. Okay, so this is the kind of stuff that's on the wards in Wexham Park. The other thing that's very interesting to me is most of the activity in hospital is done within the first 8 days of admission. And actually what the models that I would be looking to establish is I want to look at those who are over the age of 85 who breach 8 days. So I think we need systems within the hospital to have a fresh pair of eyes for patients who breach 8 days in hospital, who, if the hospital team haven't managed to rescue them and resurrect them within 8 days, there's something wrong. They may be social, they may not be dying, they may have really complex medical things, but I think it's another pair of eyes needs to stand at the end of the bed and look what's in the bed and speak to the team about what are we really trying to achieve for this 92-year-old lady in this bed who's on day 46 of her hospital admission. And the kind of stuff that is in hospital is what you would expect. Stuff that gets trapped in hospital are older patients, ethnic minority groups, particularly the Chinese or other ethnic minority groups where the survival is predominant, so the survival never slides down. So every second counts, every minute counts, and we can't slide the survival down, and they end up in hospital on chemotherapy, on intensive care, and die on treatment. But this is the really important thing here. So quite often what's in hospital is where we've got dispute in the family. Okay, so we all work with complex families, and if there is discordance in the family, where the patient ends up is hospital usually. You'd much more like to make it for a home death if you're educated with and wealthy and married. The other stuff we've got in hospital is very high levels of comorbidity. Okay, so these are very complex patients with multiple diseases, which makes their prognostication really difficult. So it's really hard to work out who is dying and who isn't. And I thought this was really interesting. I just wanted to make this point, really. So we try very hard, aren't we, to work with patients for their choice. And the mantra out there is that patients want to die at home, with their children around them and their hair flowing on the pillow and their Laura Ashley sheets and all the rest of it. Those of us who deal with dying know it's not like that. It is not. It goes on and it goes on, and it's exhausting. But if you ask people who are well on the telephone, when they have no real experience of dying, what they want to die at home. If you ask people without cancer where they want to die, they're more ambivalent about that. They have less of a vision for their end of life. I think that is really interesting. I don't know why that is, but I think we need to look at this, really, because this is not such definite dying. They're not in the zone at the point of diagnosis of their COPD. They think thank God I've got lung cancer, I've only got COPD. Okay. So in hospital, this is what we've got, large volumes. of elderly patients who are very complicated. Large volumes, elderly patients who are the most complex. And the systems really for me are to look at the identification in the hospital, help you in general practice to find them, because they will come in, get them out, package them up sustainably with a really meaningful plan for the end of their lives. And that's all about systems. It's not just about clinicians, it's about systems and process and resources. I will tell you that specialist palliative care is very good at this. So there's lots of work going on in frailty at the moment. I feel like they're reinventing the specialist palliative care model, but I have to try and keep my gob shut in some of these meetings. But we know that specialist palliative care can do this, and the only model of intervention that has reduced length of stay and hospital readmission. So the frailty models do reduce length of stay, but they don't impact readmission rates because they're still not being honest about what's happening to the patient. They're re-abling the patient. They're not being honest about the fact that they may deteriorate and die. The only thing that will influence our readmission rate is a specialist palliative care model. So we need to invest in specialist palliative care models if we really want to get people home and keep them out of A&E. And we need to run a system of palliative care and end-of-life care, which we need to change our philosophy of care from curative treatment to chunk you were dying and you look like that person in the bed, to wrapping the care around, working alongside our acute physicians and alongside our GPs. So I tell you, I've just come from a clinic this morning and I run a palliative care clinic in the lung cancer clinic on a Tuesday morning. And the reason we set this clinic up is that we know the evidence is, if you run a palliative care clinic alongside a lung cancer clinic, the survival is better than chemotherapy. So there is a reason to invest in clinicians and expertise, not just drugs, in a palliative situation. And the reason probably the survival is better is, one, that we are obsessed about detail, so we're very good at looking at constipation management and opioid management and managing the detail, but also that we are very good, we're not scared of stopping the chemotherapy, so we're not scared of having the conversation at the point where the chemotherapy becomes life-shortening rather than life-prolonging. Okay, so those conversations happen when they need to because we have time and the support and the expertise to do it. Lost it. Don't worry, I think I've finished. I've finished. So I think, in summary, really, what I'm saying is this is really difficult work. Don't beat yourself up about it, it's hard. And pull in the resources, there is expertise out there to support you, but not enough, and it's massively under-resourced. We need more resources in specialist palliative care if you really want to pull off hospital avoidance and reduce length of stay. I would say to you that we can put in the models and the systems, but these are people and they are individuals, and we must never ever lose the individualised care that we need. And we learned that lesson, didn't we, with the Liverpool Care Pathway. We tried to put in very well-meaning systems, and they were abused in the generalist setting because people didn't understand the complexity of the work that we were doing. It was too belittled, the end-of-life care was too belittled, and clearly this is not a tick-box exercise, this is really complicated work. So you've got to hold on to your humanity in the individualised care that you give, and we need to invest in the systems and the processes, and we need to wrap palliative care alongside acute care, but particularly frailty work, particularly that work. Thank you.
Thank you so much, Fiona. Such a challenging area, and I think the patients you've been describing are exactly the ones that we are, as GPs, certainly grappling with in the community as much as everyone is in secondary care as well. If you don't mind, I just had one quick comment for you, because you were mentioning about having the conversation or not having the conversation when patients are acutely unwell on an acute ward, and that it's better to then slag to GPs once they're discharged. But the challenge I find as a GP is that when we then try and start these conversations, not always, but sometimes the patient will say, but my specialist didn't say that, they didn't say it on the ward at all, and therefore you're starting at quite a difficult place. I just wondered if you could comment on that.
No, I'm so with you. In fact, we do this training with VTS ST3 trainees, so we bring actors in and we make them have this conversation, and we make it non-malignant disease, and we make them practice going around to somebody's house after they've nearly died on intensive care with a non-malignant disease to ask them, you know, all of your open questions. How was it? You know, how was intensive care? You know, and you know, try to get a feel for what they want for themselves. You're absolutely right. If we're being undermined by our colleagues elsewhere, then it's impossible to move the patient. So when I talk about moving ourselves, we haven't just got to move ourselves, we've got to move our colleagues. Everybody has to say the same thing. So there is a huge amount of education to be done in secondary care. And the way that we communicate that across to primary care is very tricky, because these patients come home and they read their discharge summaries. So they have access to the communication that we give them when they leave hospital. So it's dangerous for them. I could write a book about the stuff I've seen done. You know, DNA CPR is going out in the post with compliment slip from Wexham Park. So it is really tricky stuff. So there's lots of education, and I actually, for me, what we encourage junior doctors to do and our team to do is we ring the GP, because I have never ever had a GP who I've rung who wasn't interested in the conversation. So if you call the GP and say this patient's on their way out, you know, they know this, but they don't know this, but I think they'll die within 3 months. I've never had a GP not be interested in that. In fact, so they've always said thank you so much for the information. So that communication across the boundary is very tricky, but how we systemise that is really hard, and the volume is enormous. The volume of patients is so big, so we have to look at the systems. Yeah.
I can just add to that. One of the things on one of our slides was about being present in the conversation. And we know that there are times when people can't, under the influence of alcohol, when they're in pain, when they're extremely tired, they're not going to be able to be present for much of a conversation. And I think that's back to the communication between professionals and just flagging, you know, just saying, we need to have a conversation with you about this, and now isn't the right time. Because then it's open to be picked up in the future, and I think that can be extremely helpful.
Yes. I think also the other side is that sometimes we're not able to answer the questions, are we? So they say to me, you know, you're in the canteen buying a sandwich and you meet your patient and they say, am I dying, doctor? And it's just not the right place. So what we teach everybody to do is you hear the question, you have to hear the question. Goodness me, that's a huge question. I can't talk to you now about it, but I've heard it, because the courage to ask that question is absolutely enormous. So they may have, in fact, they've probably chosen that location because it's probably the safest place to do it. So they either choose a really bizarre location or they choose the most junior member of the team. So they choose, when they're in the bath, they choose the nursing auxiliary, you know, who isn't going to know the detail, but they choose somebody unscary or an unscary location. So you have to, as you all know, flag it, hear it, I've heard it, I can't deal with it now, but I will be back at 2 o'clock and I will bring the oncologist with me, or I will bring the GP with me, or I will, you know, you give them a plan if they have the courage to ask.
Any quick questions from the floor? There'll be more opportunity. Yes, later.
GP. The other difficulty is not just when patients aren't told. They may not have even had an admission, but it's this comorbidity business, and they're under 6 different specialists in outpatients, perhaps. And each specialist is doing their bit for their particular thing, and if that person just had their one thing, just their renal thing or just their heart thing, then they might well be getting okay. But by the time their renal treatment has upset their heart failure, and then they've got gout, etc., etc., etc. And it's really difficult sometimes to be able to sort of persuade the patient that actually they don't have to, they almost feel obliged to keep going, because each consultant individually, and even if you speak to one consultant and say, you know, there's still the other 5 who are still ploughing on, and it's really difficult to manage that when you're looking at them as a whole, and you can see them now compared to how they were last year or the year before. Even without an admission, you can think this is just going nowhere, and we really ought to be, and that can be difficult to manage as well, because it's not just the admission, not being told in admission, but all these multiple appointments, nobody's telling them they're getting to it, and I find that quite tricky as well.
So I think you're right, and I feel in a way I'm sort of preaching to the conversion in here. So your GPs who are used to multi-morbidity, you're used to this, the vision of care, the trajectory of care, seeing patients over a long period of time. So I hear you, it's very tricky work. I mean, I think I have a very low threshold for calling everybody on my phone. So I have to get everybody in the room before I can make the decision I need to make for the patient, and so that may involve calling 6 different specialists and getting them. I have to systematically shut the doors. I have to shut the doors, and then I can get the decisions made. And I find that's easier to do on the telephone. I mean, nearly always when I ring the oncologist and say, actually, are you serious? Really? Chemotherapy? Are you serious? They go, oh, no, not really serious. But it's hard to write that down in a letter. So I think we need to get back to the old days when we used to speak to each other, ring each other up and talk about, actually, I think this patient might be dying, what do you think? And I'm quite used to being called by GPs who are in care homes with a patient with dementia with them and saying, I just need to say this to you, I'm just going to say this to you, I'm feeling like I shouldn't have been this, is this the right thing to do or not? And of course that's such excellent practice. I mean, that is Bowen principle, isn't it? Such excellent practice, because all you're doing is checking your decision making, making sure that somebody else in the same position would have done the same thing as you. But ultimately you're in charge. The GP lives at home, not in hospital. The patient lives at home, not in hospital. You're in charge of their care. You're the primary care coordinator. I think in general practice you need to take back the control, and I suspect the way to do that is on the phone.